right, so I see that there are a few other people that I don't know that have joined today. So I'm Shelley Wall. I'm one of the other burns consultants in Pietermaritzburg. And today I'm going to be speaking about analgesia for burn injuries. So we're going to be looking at types of pain, just to revise from last week. Nikki did do it last week as well. Burn pain, the hypermetabolic response to burns and how that influences pain, and analgesia. We're going to look at our protocols in terms of background analgesia. We're going to look at neuropathic pain and complications of inadequate analgesia. So despite the availability of effective analgesics, an unacceptable number of patients continue to experience intense pain. And the reason for this is multifactorial. So one of the reasons is that often we haven't got the drugs available to us that we would like to have to manage pain. So for example, gabapentin and clonidine, we haven't had at our hospitals for a significant amount of time, about 5 years now. And another reason is because of people's attitudes towards burns patients. A lot of people believe that burns are just painful and that no matter what you do, these patients are going to be sore. But if you constantly reassess their pain and you think about the reasons why the analgesia might not be working and adjust your strategies, it is actually possible to get adequate pain control in these patients. So Nikki put the slide up last week. I've just added neuropathic pain, but last week she dealt with procedural pain. This week we're going to be looking at resting pain, which is dull in nature, but of long duration when the patient is between procedures. And we're also going to touch briefly on neuropathic pain. So when you're prescribing analgesia for a patient with burns, you need to realize that there are different types of pain, as we described in the last slide. And you need to make sure that you prescribe different medications for the different types of pain. In a lot of centers, they give Panado and Valeron for background pain, but then that is the same analgesia that's prescribed for procedural pain. And the different functions, different drugs to give with different functions for each of these different groups of or different pains that burns patients experience. So when you're prescribing analgesia, think about what you're prescribing and make sure that you're prescribing something for background pain, something different for procedural pain. And if the patient has neuropathic pain, that you're prescribing drugs that are specifically going to target neuropathic pain as well. There isn't one pain medication that covers all three of the different types of pains that these patients experience. So burn pain is dynamic. Burn pain changes through the course of the burn and through rehab. And it's very important that we constantly reassess these patients, reassess how they are experiencing pain, reassess the scripts that are written to make sure that things haven't been changed as the script has been written, that things haven't been left out, and to make sure that the dosages are adequate for these patients. We also need to be cognizant of the fact that different individuals experience pain differently. So two people that are of the same age with the same size burn and the same depth may experience pain exceptionally differently. And it all stems from previous experiences, and we all have different pain thresholds. So if a patient is experiencing pain out of proportion to what you think they should be experiencing pain, you still have to take it seriously. You can't just ignore their pain and just say, oh, they need to toughen up. You need to actually be cognizant of the fact that this patient might just be have a lower pain threshold and might need more analgesia than another patient. We also work with people from a lot of different cultures, and it's important to remember that some cultures, it's not okay to admit that they have pain. It's not okay in their culture to complain. And these patients may very well tell you that they have no pain and tell you that they're okay, but they might still be experiencing pain. So we need to counsel our patients and explain to them that they shouldn't expect to be in pain and that we need to know if they aren't so that we can adequately analgesize them to make the whole rehab process and the wound healing, make it a better experience for the patients. And pain that isn't treated does actually influence wound healing as well. So we need to give them the opportunity and tell them that it is okay to tell us that they are experiencing pain. Don't ever have delusion of adequacy. Do never believe that you are giving the adequate pain medication just because you've written up the dose that's written in the guideline. Make sure that you actually do assess the patients and make sure that the drugs that are written up in the guidelines are actually being effective. And if they aren't, you need to find other solutions. The hypermetabolic response to the burn is it influences the pain that the patient experiences, and it influences the response to the analgesics as well. The hypermetabolic response results in altered pharmacodynamics and pharmacokinetic responses to drugs, including analgesics. And Burns patients have a wide inter-individual and intra-individual response to drugs. So I've already said that different people experience pain differently and they respond to analgesics differently. But one patient themselves can respond differently to drugs this week to how they do next week, depending on where in the hypermetabolic response they are, whether they're in the ebb flow, phase or the flow phase. And the pain experienced in Burns will change over time. In the first phase of the hypermetabolic response, these patients are often hypovolemic. They have edema, hypoalbuminemia because they're leaking a significant amount of their albumin out through their wounds. And they often have a low glomerular filtration rate, which results in slower drug distribution and lower renal clearance. After 48 hours, these patients then go into a hyperdynamic state where they have altered protein binding, altered drug distribution, and altered drug clearance from increased renal and hepatic blood flow. And depending on the drug, they may even lose some of the drug through the exudate leakage. So all of this influences how the patient's body responds to the analgesic. And they don't respond like other trauma patients or other general surgery patients would to the same analgesics. So you're going to hear this word many times today. You need to have a dynamic approach to burn management because burn pain is dynamic. It changes. So you need to continually reassess the patient and make sure that the analgesia requirements are being met and that the analgesia that you have written up is adequate for the patient. You need to regularly adjust the analgesia regime. So you need to look at doses. You need to make sure that if you are seeing the patient for the first time, that the person who saw the patient before you has been giving adequate doses. We don't like practicing homeopathy and giving patients doses that are not adequate. If you're going to give a drug, make sure that you give it at an effective dose. And you also need to make sure that the dosing frequency is correct. People often write up incorrect dosing frequencies because they're scared of giving too much analgesia. So if you look at our protocols, this is our protocol, the Burn Care, the PMB way protocol for background analgesia. So for every single pediatric patient, they get paracetamol and tilidine, which is Valeron, and make sure that you prescribe each of these 6 hourly, and adult paracetamol and tramadol. And again, tramadol is 6 hourly, not 8 hourly. Often people prescribe it 8 hourly because that's what's practiced in other disciplines, but it is 6 hourly. So just to summarize that protocol and something that's a bit easier to see, I work better in pictures. So those of you who do as well. Background analgesia for pediatrics is Valeron plus Panado. If they're still in pain and they have a normal U&E, you can add Brufen. And if they're still in pain, you can add Needit. And the reason for this is if we give them everything that we possibly have right from the first day, when they do develop tachyphylaxis and get used to the drugs, or when they go to theatre, we have nothing else to add for them. So if they are adequately analgesed with Panado and Tramadol, leave them on that until they require any additional analgesia, because then you've got more wiggle room and more options with what to give them down the line. Never prescribe Brufen to an acute burn without checking the U&E, because often these patients are hypovolemic and they may have an acute kidney injury, and Brufen obviously is nephrotoxic. For morphine, when we do prescribe it, we don't give IMI morphine. We give oral morphine for Burns patients. The majority of the general surgery and trauma patients that are seen in surgery or by surgery registrars and surgery consultants have gut pathology. And as a result, they don't have enteral tolerance. But the Burns patients, with the exception of the septic ones who have diarrhea and vomiting, Burns patients generally have good enteral tolerance. And as a result, oral morphine is perfectly acceptable. And this helps the patients to avoid painful injections because they already have enough pain. They don't need to have painful injections every 4 to 6 hours either. Oral morphine does work, has a slower onset of action than IM morphine initially, but once you've been given giving the patients oral morphine at regular intervals, the MRC is reached. And then as long as you continue giving the oral morphine at regular intervals, it's just as effective as IM morphine without the painful injections. So we still give IM morphine in the clinic for dressing changes purely because of the rapid onset of action. But if you're giving it for a duration where every 6 hours or every 4 hours you're giving it, you will reach the MRC and it is just as effective. So this is just to highlight the doses. Please make sure that you give the correct doses of the medication and that you give it the right intervals. And for morphine, don't be scared of morphine. If you need to give it, if the patient is still in pain despite the other analgesics that you've prescribed, we start at 0.2 milligrams per kilogram 6 hourly. You can then increase that to 4 hourly or to 2 hourly. And then once you've reached 2 hourly, you can increase the dose by 25%. A patient who is in pain is not going to stop breathing on morphine. The one caveat to that is that you need to just make sure that the patient's renal function has been checked and that the renal function is normal. If you're giving tramadol and morphine to a patient with an acute kidney injury or renal dysfunction, that may accumulate because both are excreted through the kidneys. And if it accumulates, you're going to have a patient that is exceptionally drowsy and will end up with very slow and very shallow breathing, and that'll obviously cause a problem. So if a patient has renal dysfunction, you'll then need to alter the doses of tramadol and morphine and potentially stop one of them. Anxiety and pain go hand in hand, and you cannot separate them. Somebody who is anxious does feel pain with more intensity than somebody who isn't anxious. You need to assess your patient to see whether they're anxious, and that is also contributing to your struggle in trying to control pain. So if a patient has anxiety on top of the pain, you need to add Valium. If a patient is having symptoms of acute stress disorder or PTSD, where they're having flashbacks or they're having nightmares, you need to make sure that you treat that and add the Valium, because that will in turn allow you to get better control of their pain, and you potentially won't need as high doses of your analgesia as well if you are managing the anxiety adequately. This is obviously easier to assess in adults who can talk to you and verbalize what they're experiencing. In children, they often are screaming at night. You can see that they're exceptionally anxious when you approach. They scream whenever any doctor comes near them. But again, it is slightly more difficult to assess anxiety with these patients. And it's useful to chat to the mom and find out if the mom is experiencing that the child is different to how they were prior to the burn. The moms know their children best. If the patients are not sleeping at night or they have pain at night, you can add amitriptyline. And people who have not slept, they already have a lower pain threshold and they do experience pain more. So you need to make sure that you can try and get your patients to sleep as well as possible to try and help them with pain as well. So if you have a patient who you suspect has anxiety or PTSD, then you need to give the patient Valium. So for the children, we start at 2.5 milligrams Nocte and titrate to effect, and this can be increased to 8 hourly. And for adults, 5 milligrams Nocte, and you can titrate that to up to 5 to 10 milligrams 4 hourly. Sorry, I see that there's a question here. Is there a role for PR morphine as they do oncology for patients with enteral intolerance? I think it depends on whether they've got diarrhea or not, but it's not usually a problem. Most of our patients have enteral tolerance, and we give them oral morphine. And the ones who don't have enteral tolerance usually have diarrhea. So I'm not convinced that the PR morphine will be much use in those situations either. Does that answer your question? I'll carry on. You can let me know if it doesn't, and we'll address that afterwards. So just a short word on neuropathic pain or burn-related nerve pain. This is the manifestation of pain related to either the burn injury itself or management of burn injury resulting in direct injury or irritation to a nerve with subsequent signs and symptoms of pain. It contributes to a decreased quality of life, long-term morbidity for the patient, and limited functional recovery. So a patient who has chronic nerve pain, they end up not sleeping, they aren't able to continue with their jobs, and it really is debilitating for these patients. So we need to make sure that we try and treat this pain within the limitations of the drugs that we have, but we try and treat it as best as we can. Some patients, no matter what we do, they always are going to have a limit of pain in terms of the neuropathic pain, purely because in the state we don't have the drugs available, but we can offer them private scripts to get gabapentin if they need it. So for neuropathic pain, clonidine is great, but again, we haven't had that for a while. But if you do have access to clonidine, please use it. And these are the dosages for it. If patients have pain at night, as I said, or difficulty sleeping, amitriptyline is useful. For neuropathic pain or patients who have severe itch. So a lot of the patients complain of debilitating itch, and gabapentin was excellent for that. But unfortunately, again, we don't have that in the government sector at the moment. However, we have given some patients private scripts, and they have continued to request it after they've used it once, because it works really well. Pregabalin or Lyrica is another option. However, it is more expensive than gabapentin and also not available in our setting. Another thing that we found works for neuropathic pain, if there is no Tegretol no gabapentin or pregabalin, is Tegretol. So we give it to the adults 200 milligrams 12 hourly and increase to a max of 1,200 milligrams per day, which is 400 milligrams 8 hourly. The problem with this is that it's not safe to use in children. So that is a problem. If the patients do have itch and you haven't got pregabalin or gabapentin, then we do give Allergex. It works for some patients. It doesn't work for everyone though, but we do give it and see if it does help. And the patient will tell you if they want it, if it helps or if it isn't helping them. Consequences of inadequate analgesia are complex pain syndromes, neuropathic pain, depression, delayed wound healing because of the physiological sequelae of inadequate analgesia, sleep interference, and anxiety. So all of these things are really not ideal for the patient, and we need to make sure that we treat pain adequately to try and avoid all of these. If we have patients that have adequate background analgesia, they require less procedural analgesia, and patients are also more compliant to exercises and therapy if they are not experiencing pain. If you're lying in your bed constantly in pain, you're not going to want to eat properly, you're not going to want to comply with anything that anybody asks you to do. So we need to make sure that we adequately analgesize our patients. So the take-home message, burn pain is dynamic, and I'm sure that you would have gotten that out of today. You need to constantly reassess the pain of the patient and the analgesia regime that you have written up, and adjust it as necessary. Don't be scared to give patients morphine, and don't be scared to increase their dose if you need to. Prescribe drugs for both background pain, or for all background pain, neuropathic pain, and procedural pain. And don't expect Panado or one drug to treat all of those types of pain. You need to address each one individually and make sure that the drugs you've prescribed are targeted at the different types of pain. And if the patient has anxiety, treat the anxiety, because it's going to be very difficult to get control of the pain if you don't treat anxiety when it is required.